Hello everyone, my name is Daniel McCormick of the Ontario Drug Policy Research Network and ICES, and I'm here to speak to you today about opioid agonist treatment retention across demographic and geographic subgroups in Ontario. Opioid use disorder remains a significant public health issue in Canada, with almost 30,000 deaths over the last 5 years. Opioid agonist treatment, or OAT, is supported by a large body of evidence in reducing opioid morbidity and mortality. The two most common types of OAT in Ontario are methadone and buprenorphine naloxone, or Suboxone. The chart you see at the bottom are the number of unique individuals dispensed either drug in Ontario over the last 8 or so years, with methadone in yellow, the far more common drug, and buprenorphine naloxone in purple. Our objectives for this current study were first to understand differences in time to treatment discontinuation between OAT therapies, and also to identify patient and geographic characteristics associated with OAT retention. Our study population included residents of Ontario age 18 or older who had initiated buprenorphine naloxone or methadone between October 2016 and December 2019. We excluded individuals who had received an OAT claim 180 days prior, indicating that they were not initiating their treatment. And we also excluded individuals residing in Northern Ontario due to incomplete linkage of data for First Nations. In order to receive publicly funded healthcare, First Nations individuals can present either their Ontario Health Card or their Indigenous Status Card, and that can create issues in terms of data linkage. We followed individuals from treatment initiation for a maximum of 3 years. Our main outcome was discontinuation, which we defined as more than 14 days between the end of one prescription and the beginning of another. And we censored on death, end of follow-up, so a maximum of 3 years, and if they had switched therapies. So if they were taking methadone and then suddenly received a buprenorphine naloxone prescription, or vice versa. The number of days on each treatment was modeled using Kaplan-Meier curves and stratified by sex, rural residence, and age group. And we used log rank tests to test for differences between treatments and between stratifications. At baseline, we found that the two patient groups were similar in terms of gender and urban residence, but that patients receiving buprenorphine naloxone were slightly older and had a notably lower percentage in the lowest income quintile. When looking at previous healthcare use at baseline, we found that buprenorphine naloxone patients had a higher prevalence of mental health conditions, prescription opioid use, and emergency department visits for any reason. Here we have Kaplan-Meier curves representing the proportion of individuals retained on treatment, with methadone in orange and buprenorphine naloxone in blue. And as you can see from the table, methadone patients were retained on treatment notably longer than patients receiving buprenorphine naloxone. And from the log rank p-value, you can see that this difference was statistically significant. Within each treatment, we stratified by various patient and geographic characteristics. We found that methadone patients in rural areas were retained on treatment significantly longer than methadone patients in urban areas. We also found that time on treatment increased with increasing age group up until 65 plus, where we had limited data. We looked at the same stratifications for buprenorphine naloxone and found that women were retained on treatment significantly longer than men, and a similar trend as with the methadone patients, where time on treatment increased with increasing age group up to 65 plus, where we had limited data. Some notable strengths of the study are that we used real-world data from a large population, the population of Ontario. Our OAT dispensing records were sourced from the Narcotics Monitoring System, which contains data on dispensing of all controlled substances in Ontario, regardless of payment method. So it's very comprehensive. Some notable limitations are that Kaplan-Meier analysis does not adjust for confounders. We, as I mentioned before, we excluded residents of Northern Ontario due to data linkage issues, and therefore these results may not be generalizable to this population. And finally, that access to OAT can vary widely across jurisdictions. Some implications of the study are that treatment should be tailored to patients' demographic and geographic characteristics, and that the greater safety profile of buprenorphine should be weighed against the increased risk of discontinuation compared to methadone. In terms of future directions, efforts should be made to explore new buprenorphine products with different formulations such as Probufen and Sublocade for increased retention. I would like to conclude by thanking everyone else who worked on this study and provide my contact information if you have any questions. Thank you very much.